All right, everyone, welcome to our first vascular webinar. We have our, very famous Dr. Vatakencherry to start
Oh,
his
give me a
wonderful
break.
lecture. Yeah, we're all excited. Oh, here for
Why are you
you.
making fun of me again?
I'm
Is this
not.
just like teasing after internship, huh? So
Uh-huh.
good Dr. Lou rotated with us as our intern, so he's probably getting back at me with those comments, but it's all good. All in good jest. Awesome. So should I start?
Yes, let's
All
do
right,
it.
cool, thank you. So basically, this is going to be a part of the webinar series on kind of vascular medicine, vascular disease, and PAD, et cetera. So I'm going to really focus on the medical management of peripheral arterial disease. And really, there has been a paradigm shift. So let's kind of discuss some of the things. And let me also talk about no disclosures. So one interesting thing that's happening in the US, and I think we need to pay a lot of heed to this, is the life expectancy for the last 3 years has consecutively been declining. And it's not like that we've had the highest life expectancy when compared to the rest of our neighbors in the world, but the fact that it's declining is dangerous. Now, there's many reasons. It could be the opiate overdose, suicide rates, and progressive liver disease. But certainly there are certain things that we can manage, including reducing event rates from patients with coronary artery disease, cerebrovascular disease, which are still the number 1 and 3 killers in the U.S., and also potentially reduce cancer rates by a lot of preventative methods. So I think we, as a society of physicians taking care of patients and educating patients, need to do better. Now, peripheral arterial disease is exceedingly common, okay? And it's really underdiagnosed. And we have a growing population of older patients, diabetics, and smokers. So we have a large population. And there's a growing abundance of level 1 evidence to help us figure out what to do. Because as physicians, we have to use quality data to guide us as far as pharmacological adjuncts or non-pharmacological adjuncts in order to get the best outcomes for our patients. So one of the big problems that we're seeing in the US is obesity, okay? And that's leading to a ton of problems. A lot of diabetes and the sequelae of diabetes, whether it be end-stage renal disease, loss of limbs, neuropathies, retinopathies, etc. High cholesterol, obstructive sleep apnea, coronary artery disease, high blood pressure, and arthritic problems. Now, when you're looking at peripheral arterial disease therapy, we know it's very common, and arguably between 10 and 20 million patients in the US will have PAD of some sort. We now have to figure out what are we going to do as a physician managing these patients. What are our key goals? Well, number one, you have to keep them alive. You need to reduce the risk of heart attacks and strokes and the morbidity associated with cardiovascular events, heart attacks and strokes. Number two, you want to keep their legs. You want the patients come in with the 4 limbs, they want to leave with 4 limbs. So you want to prevent amputation. And that's primarily in the critical limb ischemia patient population. So we want to kind of address CLI and revascularization. And there's a whole slew of CLI fighters that are various disciplines that are really attacking this disease process. And then finally, we want to improve the symptoms of claudication, because though claudication is not likely going to cause life-threatening or limb-threatening condition, it is a bothersome issue that impacts patients' quality of life. And so we certainly want to address that, because we want to keep patients not only alive with both limbs, but we also want to keep them happy and functional. So what are my goals? Well, I really want you to realize the importance of 3 medications, really: statins, ACE inhibitors, and antiplatelets, and understand that these medications have transformational results in patients' outcomes. The importance of exercise and cilostazol in claudication, and why that's so important from a non-interventional standpoint of how you can have tremendous impact on patients. And finally, I want to talk about diabetes in general, but really some of the new diabetic medications and some of the information about smoking. All right, so how common is this? Well, this is an interesting study by Alan Hirsch, published in JAMA 2001, where he just looked at a kind of family practice population of older patients over 70, 50 to 70, and they looked at the incidence of PAD, and it was as high as 29%, okay? And of that, half had PAD only. And the interesting thing is, even if the patients knew they had PAD, the primary care physician was unaware that they had PAD. So again, it's an underdiagnosed and unfortunately undertreated condition, but this disease is serious, and it does lead, it's a surrogate of vasculature problems in the coronary and the cerebrovascular system. So it is important to identify, diagnose, recognize, and treat aggressively. And that is my goal today for you all that are going to see patients with diabetes and hypertension and smoking that have possible PAD that are either underdiagnosed or undertreated, to stop that trend. And hopefully you'll be part of the solution. So the two key risk factors in peripheral arterial disease are really smoking and diabetes. So every diabetic, every smoker, you need to do a thorough exam of their cardiovascular, cerebrovascular, and peripheral vascular system, all right? Because these patients are at very high risk for event rates. So anytime you're dealing with any disease, whether it be oncology or vascular conditions, you really need to know the natural history of the process, okay? So is it a life-threatening condition? Is it a limb-threatening condition? Is it a bothersome symptom? These are all important for you to understand, because that's going to be important when you're guiding and counseling patients as to what to do. So let's look at PAD and how they present. So if you look at the global population of PAD, remember I said about 10 to 20 million patients in the US will have it. Only a small percentage are going to have what's called critical limb ischemia. And critical limb ischemia are the ones that we're worried about losing their leg. And they're very, very sick patients that are sicker than many cancer patients, right? Now let's look at the other patients. Only about a 10 to 20% are going to have what's classic claudication, where they have a calf pain. When they walk a certain distance, they stop, the calf pain gets better. Many, up to 50%, are going to have atypical leg pain, because remember, these patients are going to have spinal stenosis, they're going to have hip arthritis, they're going to have plantar fasciitis, they're going to have all these other things that elder patients will have. And it can be confusing as to what the source of the pain is of their leg. And then many of these patients will also be asymptomatic with blockages of their lower extremity arterial system. Let's look at critical limb ischemia. You know, again, 10 or 20 million patients are going to have this in the US, and it's clearly underdiagnosed based on the partner trial and certainly undertreated. What is the outcome of critical limb ischemia? Well, if you look at the one-year outcome, a quarter are going to have a significant cardiovascular, cerebrovascular event and potentially die from that, okay? A quarter are going to have an amputation, and only half are going to be alive with both limbs. So this is sick. Like I said, it's worse than many cancers. Now let's look at the claudicant, atypical leg pain / asymptomatic PAD. What happens to them in 5 years? Now I think it's a misnomer to think that these patients are going to lose their leg, because only a small percentage are actually going to lose their leg, right? So only a few percent of these claudicants or atypical leg pain or asymptomatic PAD patients are going to lose their leg. It's kind of like an angina equivalent in the coronaries, right? Whereas unstable angina is kind of like the critical limb ischemia, or the acute coronary syndrome is the critical limb ischemia of the leg. So when you look at CLI, okay, we talked about how a quarter are going to lose their leg and another quarter are going to be not alive, right? They're going to be dead. Well, in the claudicant population, let's look at their natural history. A third are going to die, all right? And the majority of these are going to be heart attacks and strokes. So again, these are preventable conditions with modern medications. So again, if you look at the critical limb ischemia patient in 6 months to a year, only a half are going to be alive without an amputation. One quarter are going to be have a mortal event, and a quarter are going to lose their leg. Now, this I think is a very useful stratification for claudication or chronic limb ischemia, okay, and critical limb ischemia. So really, the first 3 stages are kind of the top, where they have a high risk of heart attacks and strokes, but they're not going to lose their leg. So that's asymptomatic, mild, moderate, severe claudication. The final 3, which is rest pain and then minor and major tissue loss, 4, 5, and 6, are the ones that are high risk of limb loss and cardiovascular events as well. So rest pain is pain in the foot that is all the time. They may have what's called dependent rhubar or pallor elevation, where it's kind of red when it's dependent, and then as you elevate it above 15 degrees, it gets kind of pale or blanches. That's kind of an imaging or a clinical finding that you identify these patients, but they're going to dangle their foot or sleep in a chair because they're gravity dependent for flow. They're ischemic at rest. Okay, so that's bad. Again, kind of like an unstable angina of the foot. Now, when you start getting tissue loss or a non-healing ulcer, now you have inadequate circulation to improve the wound. That most humans, like most people, have adequate flow to oxygen and circulation and flow to the foot to heal. After you get a wound in your foot, most people, if they're not diabetic or they have good circulation, they'll heal their wound pretty quickly, you know, within a week or 2. But these patients will not have, they'll have impaired healing from their diabetes and also from the lack of circulation and sometimes underlying infection. So that's an important concept. So again, Rutherford is a very good way to stratify patients with PAD, and I encourage anyone who's seeing these patients to stratify them in that fashion. Are they asymptomatic? Do they have claudication? That's 1, 2, and 3. Mild, moderate, severe. Or do they have critical limb ischemia where they have a quarter chance of losing a leg in 6 months? And that's rest pain onward, okay, to minor major tissue loss. Okay, so again, what is my #1 goal? Well, it doesn't do you any good if you open up the circulation with a very elegant interventional procedure, but the patient dies in a month or 2 of a heart attack or has a major stroke, is now aphasic, can't talk, can't walk, can't eat, they have a G-tube. That'd be horrible, right? So you haven't done the patient any good service. And if you're gonna, be seeing these patients, you should certainly manage these conditions. And some of the things we have to do is really start to educate these patients, whether it be claudicant or CLI patient, to consider changing their diet and exercising. Something I do is I just have them pull out their phone and look, how many steps have you done? And that's really any patient that comes to our clinic. All patients or all people, all of us should be trying to ambulate about 10,000 steps. And so that's something that's very easy. Most people have a cell phone this day, and you can showcase that on their phone, how many steps they've been doing, and track that. Now the BMIs and also waist size are also important, and it is kind of ethnically driven. So if the South Asian population need to live at a lower BMI and a lower waist circumference, so recognize that, and that is also a surrogate of event rates in the cardiovascular, cerebrovascular, and peripheral vascular beds. And again, we're going to talk about statins and LDL reduction, ezetimibe, and PCSK9 briefly. And is there a role of DOACs, or these new direct oral anticoagulants and antiplatelets, and ACE inhibitors, and what kind of blood pressure control, smoking cessation, and then diabetic control, especially some of these new drugs like the SGLT2 inhibitors and GLP-1 agonists. Okay, so we're talking about kind of the natural history, right? Critical limb ischemia, where they have rest pain, which is equivalent of unstable angina of the foot. We talked about minor major tissue loss where they're not healing. Those patients are very, very high risk, worse than a lot of cancers. So a quarter are going to lose their leg in 6 months to a year, and a quarter are going to be dead in 6 months to a year. So only half are going to have both limbs. We talked about the claudicants. They're not at risk of losing their leg, but they will have an event in 5 years, a cardiovascular, cerebrovascular event. So we need to reduce that risk. And the way to do that is these medications. This is a 2018 guidelines for cholesterol management, and it uses what's called ASCVD, which is atherosclerotic cardiovascular disease kind of risk factors. And you can use this in a calculator, and on many of the EMRs, you can actually get that automatically driven to risk stratify patients. There's certain things such as LDL greater than 190, but regardless, bottom line is by stratifying these patients, and a PAD patient, a patient with peripheral arterial disease, automatically is a high risk patient and automatically should be in high intensity statin therapy, okay? Now, where's the data for supporting of this? Well, one is the heart protection study, which is 21,000 patients, and they looked at simvastatin, which is an older statin therapy, and compared it to placebo and antioxidants. And what they showed was when these patients on simvastatin and secondary prevention, there was a significant reduction in first major vascular events and a significant reduction in needing to reopen circulation, whether it be carotid endarterectomy or peripheral revascularization. So we are reducing major vascular events by putting these patients in the statin, and this is proven in a randomized fashion. Not only do we put these patients on statins to reduce event rates, there's been multiple trials showcasing the benefits of this. We can also improve their walking distance. This was a study by Emil Moeller looking at atorvastatin 10 and 80 versus placebo, and at 6 months, you can see a dramatic improvement in pain-free walking time. So these statins have not only an improvement in the life expectancy of these patients and reduction of major vascular events, but it also improves their functional capacity. So any patient that you see with peripheral arterial disease should be on a high intensity statin. That's usually 40 to 80 milligrams of atorvastatin or 10 to 20 milligrams of rosuvastatin. And these drugs are very safe. Okay, there may be some myologists, you coach them on that, and rosuvastatin may be a little bit better for myologists, but your goal is to have their LDL reduced by more than 50%. And you want their LDLs down, at least 70 or less, and arguably even lower based on more recent data. So let's look at this newer class of agents. So the next study was ezetimibe, which is a kind of reduces cholesterol absorption. And there's been studies comparing simvastatin and ezetimibe and showcasing that ezetimibe adds a little synergistic benefit and adds a little bit of improvement as well. So that should be a second line agent after statins in this population. And finally, most recently, in the last couple of years, these PCSK9 inhibitors have been invaluable. What they've showcased and how they work is basically the LDL receptor is kind of absorbed by this PCSK9. It gets kind of phagocytized. But if you have an inhibitor, now you have all these LDL receptors sitting on there, sucking up LDL from the blood and recycling it and having uptake. So what it's doing is reducing LDL further. And this is the main trial, the FOURIER trial. There's an acute coronary trial, and this FOURIER trial really showcased the benefits of PCSK9 inhibitors with minimal adverse events. So I think this is, again, another agent that really can dramatically reduce LDL, and most importantly, it can reduce event rates, okay? So the patient population was mixed with coronary artery disease, cerebrovascular disease, and peripheral artery disease, and the majority of these patients were already on a high-intensity statin therapy, nearly 70%. And what this randomized trial, placebo-controlled, double-blinded trial of 28,000 patients showed was we had a significant drop in LDL from 92 to 30, and the primary endpoint of a combined cardiovascular death, heart attack, strokes, and unstable angina and revas was dropped dramatically as well from 11 to 10% with a significant p-value. And the adverse events were no different. So adding PCSK9 in patients already in high-intensity statin therapy, and 70% of these patients had a dramatic reduction in LDL down to 30, and a significant reduction in event rates. So heart attacks and strokes and death were down. So I think that's important, and without increasing negative events. So meaning, when you're looking at study or looking at things, when you're counseling patients, you got to figure out, is this safe for your family member or your brother or sister or aunt or uncle? Is this a safe drug? And this showcase safety. Is it efficacious? And what does efficacy mean? You're looking at, like, are you going to keep your family member alive longer? So when you're talking to your patients, you got to do the same thing when you're reflecting. Am I keeping this patient alive? And is this a safe drug? Okay. And truly, there is no difference in adverse events. So I think that's an important drug that we're going to need to start thinking about. It's as costs go down, it'll probably become more universal. All right. So statins, ezetimibe, and PCSK9 inhibitors have a role. Certainly, anyone at this point, if it was a patient with PAD or if you've done a revascularization, they shouldn't leave, or AAA repair or whatnot, they should not leave your hospital without you prescribing them a high-intensity statin. And that's easy enough to do and very safe to do. Some of these newer drugs, the PCSK9, may be a little trickier because of cost, et cetera, but the statins certainly are a no-brainer. And I think it's imperative that you put these patients on these medications. So atorvastatin 40 or 80, or rosuvastatin 10 or 20 is a very simple thing to do, and we all should do it. All right. So let's look at the role of ACE inhibitors, and this is an important study called the HOPE trial. It's about 4,100 patients, the heart outcomes prevention evaluation. And what it showcased, when you randomize patients to an ACE inhibitor called ramipril to placebo, there was a significant risk reduction, okay? And it was independent of blood pressure reduction, which is kind of interesting, all right? And you can see in the PAD subset, there was a 22% relative risk reduction, which is not trivial. So ACE inhibitors have a role in patients with peripheral arterial disease. Now, what is your treatment goal of blood pressure in PAD patients? And there's been a bit of controversy if you look at the JNC8, et cetera. But I would argue, based on the SPRINT, which is a pretty large trial, and is not unreasonable to keep these pressures a little bit lower. Now, the older they are, you have to think of orthostasis and fall risk, et cetera. But in general, at least 130/80, if not lower, would be very reasonable. Okay, especially if they have CK, chronic kidney disease, diabetes, et cetera. Just certainly think about that. So again, statins, no-brainer, arguably an ACE inhibitor, and we'll go from there. These will keep these patients alive. So what about smoking? Well, it's really important that the simple thing to do is any patient in your office, you should ask them, do they smoke, how much they smoke, and what are the barriers to them quitting smoking? Can they pick a quit date? And then there's so many slews of tools that are free nationally and in your own hospital programs to how to stop smoking. We have a smoking hotline number. But if you just counsel a patient, you have a dramatic impact in preventing them or continuing to have them stop smoking, meaning it goes from 1 in 1,000 to 5 in 100. So that's not trivial. It's a 50-fold impact factor you have by counseling them, staying on top of it to stop smoking. Okay, there are other adjuncts like nicotine replacement therapies, bupropion or Wellbutrin, varenicline, which we'll talk about a little bit more. And I think it's important to have all those adjuncts to you, but it's simply just telling them to stop smoking is impactful. Okay, so let's look at this. So there was a lot of controversy, and even an FDA black box label initially for varenicline. And the FDA took that away because of this trial that John Doe, Dr. Lou's, junior resident, had educated me about when I'm like, hey, I don't know about varenicline because of the side effects. And he's like, well, did you check out the EAGLE trial? So if you look, and I'm going to talk about the EAGLE trial because historically they would be like, hey, these patients have suicidal ideations, they have unusual dreams. So be careful about that, especially if patients have background of psychiatric disorder. So what this EAGLE trial did was a large trial, double-blind randomized. They looked at patients both with and without psychiatric disorders, okay? And they compared Chantix or varenicline 1 milligram BID to bupropion 150 BID to nicotine replacement patch, and they looked at it up to basically 24 weeks, but the study, they continued this till 12 weeks. And what they showed was that there was a substantial, if you take the non-psychiatric group, there was a substantial difference between varenicline and even nicotine replacement therapy and Wellbutrin or bupropion. And compared to placebo, almost a 24% improvement at 9 to 12 weeks. So again, varenicline is a very effective drug. Now, what about the psychiatric cohort? In that large psychiatric cohort, again, it may not have been 38%, there was a 29% of abstinence at 9 to 12 weeks. Okay, still much higher than even nicotine replacement therapy or bupropion, and certainly higher than placebo, almost triple placebo. So this medication certainly works. And I think it's taking a lot of people, including me, like some time to go, hey, that FDA had a black box label, even though it was revoked. We were still from that initial kind of fear. But this study, I think the EAGLE trial is of quality to suggest that this is really an important drug in helping our patients who've decided that they want to quit, to guide them, to help them stop. So I think this is something that you need in your armamentarium. So just remember that, and remember this trial, the EAGLE trial. There are side effects. A quarter are going to have nausea. There are many are going to have headaches. They're still going to have abnormal dreams, and some of them may have, some issues with when they're drinking alcohol, that it may be a little hypersensitive. So there's always going to be side effects for anything. So you have to think of the side effects to the benefits, and the benefits of stopping smoking are not trivial, not just from a cardiovascular and cerebrovascular and peripheral vascular standpoint, but also from an emphysema and lung disease standpoint, and from a cancer standpoint, whether it be head and neck, renal cell, bladder cancer, lung cancer, et cetera, et cetera, et cetera. So there's tremendous impact factor if we can do this. Now, there's a lot of controversy on electronic cigarettes and vaping, and I'm sure you've all heard about it. Even Trump has been involved in this discussion, and in fact, some states have banned it. So realize these newer alternatives may not be as safe as was initially presumed. So be very cautious of patients taking those as alternatives. Now, so we realize how impactful and important smoking cessation can be for our patients. And it's our responsibility to guide them through this. And every time we see them, we have to address that subject. And eventually they're going to quit, And even if only 5% quit, it's better than 1 in 1,000. So that's a huge thing. And then if we can start prescribing them these either nicotine replacement therapies or bupropion, or even ideally varenicline based on this data from EAGLE, I think this will help them too. So really kind of work with them and the family to help them stop smoking. I think that's tremendous impact, not just from a cerebrovascular, peripheral vascular, and cardiovascular system standpoint, but from a cancer and emphysema standpoint, which are still major areas of morbidity and mortality in the US. So if we want our US population to be healthier and more functional, these are things we as physicians must do. All right. So let's look at antiplatelets, all right? And there's a little bit of controversy on what agent, why, and how, but this is kind of my take on it. When you look at the Capri trial, and I wish it was replicated, I wish we had more trials comparing Plavix versus aspirin. When you look at the Capri trial, the randomized trial, about 20,000 patients, when you look at patients either who had cardiovascular or coronary or vascular issues, the patients with the vascular issues had a reduction in event rates, okay, of 24%. So again, the PAD subset or PAD population did have a significant reduction in event rate, and you can see that here. So even though all comers may not be that great, and arguably even the myocardial patients didn't do great, the PAD subset did pretty darn good with Plavix. So in general, I tend to favor Plavix, especially now that it's kind of you can get a kind of a cheaper version, is a reasonable adjunct for your patients. Now, what about dual antiplatelet? Now, certainly there's a role of dual antiplatelet when you're putting a fresh stent or doing a fresh tibial revascularization. You want to make sure that there's no platelet activity. But what about your patients who are chronic after a year, or patients who haven't had an event, right? They're just claudicating, you're putting them on exercise regimen. What do you do for those? Well, this is a Charisma trial. What this trial showcased in 15,000 patients, when they looked at the composite endpoint of MI, stroke, and cardiovascular death, that was the same, whether you do antiplatelet or single agent, aspirin alone, but there was a higher bleeding risk and dual antiplatelet therapy. So in this situation, 2 is not better than 1. Now, again, when you're doing an intervention, that's a separate issue. That's what we're talking about. We're talking about kind of the chronic state. What do you do for these patients? All right, so these DOACs have really changed the landscape of medicine, whether from atrial fibrillation or DVTP, with multiple randomized trials showcasing the safety, efficacy, and benefit of this oral agent, right? It's a lot easier to utilize than Coumadin, where you're assessing INRs episodically. You have to watch what you eat, etc. Well, let's look at one of these factor Xa inhibitors, rivaroxaban. This was studied in the COMPASS trial. What it showcased of these 28,000 patients, when you took either 5 milligrams BID versus 2.5 milligrams BID in aspirin versus aspirin alone, what it showed is that when you look at the primary composite endpoint of cardiovascular death, stroke, and MI, there was a decrease in the combo group compared to aspirin alone. But remember, we're always looking at safety, efficacy, and durability. Yeah, the safety factor has to be of concern. There was a higher bleeding risk, 3.1 versus 1.9%. So I have some reservations. If the adverse events were the same and you're getting a reduction in heart attack, strokes, and kind of composite endpoints, fine. To me, it would be a no-brainer, but I have a little bit of concern personally because of the bleeding risk. Now, if you look at the NICE guidelines, they've actually advocated for rivaroxaban in the PAD population. So again, I'll let you kind of decide based on this trial what you would do for your patients, but just something to think about, that when you look at primary and your surrogates, yeah, it's great to stop, but there are an increase in bleeding event rates. All right. So again, a statin, so you should put them on a atorvastatin 80, right, 40 or 80, maybe ezetimibe, maybe PCSK9, but certainly a statin should be a no-brainer for everyone in the audience. Consider a low-dose ACE inhibitor. Keep their blood pressure on the lower side, 130/80, right? And in antiplatelets, you could argue Plavix versus aspirin, but at least some type of single antiplatelet should be considered in this population. And then really the importance of smoking cessation, just guiding and counseling them, right? And then use some pharmacologic adjuncts once they've got a quit date, then consider varenicline, because it has a significant improvement. And again, even in the non-psychiatric or non-psychiatric component, they still did better than placebo or nicotine replacement therapy or bupropion. So certainly think about that. All right, let's talk about diabetes. Again, the obesity epidemic is really impacting the US, and I think it's impacting a lot more than just peripheral vascular disease. I think we're seeing a lot of growth of what's called NASH, or NAFLD and NASH, and liver cirrhosis. We've done a great job in spending expensive medications to cut down Hep C, right? That's great. But now we're seeing a rise of NAFLD and NASH and all the sequelae of obesity in our diet. And I think we have to do better, right? If we want to change our landscape of where we sit in the world, diet is going to be a critical thing. And diabetes is one of those things we're going to have to attack. And it's starting earlier and earlier in our population. And certainly, as I showed you, smoking and diabetes are two of the biggest risk factors for peripheral arterial disease. All right. And what we would like is a relatively tight glycemic control. Now, again, as they're older, hypoglycemic becomes more an issue, just like blood pressure does. So you have to always weigh that based on age. But in general, goal is around 7% or less. All right. And it's mainly to prevent microvascular complications, meaning retinopathy, neuropathy, nephropathy, so visual changes, renal impairment, and the nerve issues that affect the foot, loss of protective sensation, right? So we have to always look at that. And so every diabetic, you need to educate them about this. You should at least look at their feet. Teach them how to keep their feet kind of moist, and how to look at the heel of their foot, which can be hard, or have their family members do it. And also look for little blisters in between, or the toes, tips of toes, etc. And look for calluses. All these things are bad. Make sure they have proper shoes. Make sure they don't have any stones in their shoes. These are all important things. So every diabetic, feel their pulses, and take a look at the feet and educate them about it. And you can do what's called the loss of protective sensation test, which is basically taking a little soft thing, usually it's supposed to be 10-gram monofilament, but even if you take a soft cotton and see if they can feel you. You can feel it, they should be able to feel it. If they can't feel it, then a little stone or a little rub, they won't be able to feel it and they get injured. And now they're diabetic and they may have poor circulation. That starts a cascade of critical limb ischemia and limb loss. So you want to try to prevent them by educating it. Again, that's part of our role as physicians, is to be a guidance counselor and educator. So, and there's simple medication. You should see, are they max dose of metformin? They can take up to 2 grams of metformin if their CFR is okay. If the GFR is over 30 or 45, metformin, you should take a look at it. Are they maxed out on that? There are some new drugs that may not have tremendous impact on A1Cs, but they certainly have been showing some interesting results as far as cardiovascular event rate reduction, CHF improvement, renal impairment improvement, okay? And that includes the SGLT2 inhibitors and GLP-1 analogs, and we'll talk about that briefly. So if you look at the SGLT2 inhibitors that work on the kidney and the GLP-1 mimetics that work on the pancreas, this is a whole new scan of drugs that are adding to our armamentarium for patients with PAD and diabetes. So how does SGLT2 work? It basically makes you urinate glucose, okay? So it prevents kind of the reabsorption of glucose and makes you excrete it, and thus lowering blood glucose levels. All right, so there's been multiple trials, including the Canvas trial, which was published in the New England Journal, randomized trial of about 10,000 patients. Again, the primary endpoint was cardiovascular causes, non-fatal MI or stroke. And what it showed was that there was a reduction in event rates. But one thing and there was an increase in genitalia infections, which were relatively low, but there was a slight increase in minor amputation rates, toes and metatarsal, okay? So even though the event rate reduction was lower per 1,000 patient years, there was a slightly higher amputation rate. Take it for what you will, but in the PAD patient population with CLI, I'm a little bit concerned about that as far as putting the patient on this medication. Maybe some of the other SGLT2 inhibitors are not going to have the same issue, but it's just something to think about when you're managing patients with PAD and critical limb ischemia with a wound. All right. But also, again, it's risk benefit. There's always some risk, but is there a benefit of reducing CHF hospitalizations? Maybe they're already having some microalbuminuria. Can you reduce albuminuria and reduce the risk of CKD and ESRD? Possibly. So there's another drug, liraglutide, which has actually been used as a weight management drug. So many of the diabetic meds often can cause some weight gain, but this one actually is a weight reduction drug, which is interesting. At a little higher dose, but it's still an option. So glucagon-like peptide agonist. This is a 9,400 randomized trial in the New England Journal in 2016 showcasing when you look at the primary outcomes of first occurrence of heart attack, mortality, non-fatal MI or non-fatal stroke, there was a significant reduction in those events and a decrease in all-cause mortality as a secondary event. And not really, again, not a tremendous drop in A1C, 0.4% decrease, but again, not an increase in adverse events. So this basically, you potentially lose weight, even though this study wasn't designed for that. It is FDA approved for weight loss at a higher dose. You reduce event rates, okay, all-cause mortality as well. So I think this is another agent that is an adjunct to what we're utilizing for diabetic management, besides metformin, sulfonylureas or oral hypoglycemic agents, and insulin itself. So not only do we want to drop the A1C, but maybe we add these other adjunctive things, not for really the A1C reduction, but for the cardiovascular event rate reduction, the CHF improvement, and the CKD or albuminuria improvement. So again, there's some benefits, but be cautious of some of the side effects, including the potential for increase in minor amputations with the canagliflozin. All right, so we really spent a lot of time in keeping them alive. And again, really, it comes down to, it's a global thing. So day to day, what do they eat? And I would argue a Mediterranean diet is a good way. A lot of fish, less red meats, not a lot of processed foods. I tell patients anything in a can or a bag is probably not good. Eating out is never good, So if you can cook at home, and you got to figure out what's convenient for them, because everyone's social situation is a little bit different, and figure out what's going to work for them. A food log is also valuable, and get them to ambulate, so 10,000 steps. Again, you take out their phone and show that to them, all right? High intensity statins, again, a torba 40 or 80, or Rasuva 10 or 20 is something, because you want a 50% or greater reduction in LDL, all right? Ezetimibe or PCSK9 inhibitors are going to be next line. Again, right now, at least everyone can put them on a torba without much issues. There's some cost issues with some of the other medications, but this, at least everyone can get them on board, right? So you should prescribe this patient with PAD that's in your clinic, or you've done intervention on, and before they leave the hospital, they should be on this statin, okay? You're going to impact their survival, improve their functionality as well. So I think it's very important that anyone who's seeing patients with PAD, I don't care if you're an internist, you're an interventionalist, your surgeon, whoever it is, this is just part and parcel of doing the right thing for our patients, all right? Blood pressure control, I think it should be 130 or 80. I know the JNC8 said older patients maybe live a little longer, a little higher, but I think, with the sprint trial that came out after JNC8, I think it makes sense to, maybe even go tighter. So again, obviously look for symptoms of dizziness and whatnot, and see how the patient's feeling. It's always what the patient and their family are kind of dealing with, and address that. It's a kind of a shared decision making, but think about it from a, an event rate or scientific, method, that this is an important concept. Certainly beta blockers are okay in PAD, especially if patients have obstructive CAD or CHF, that should be considered or chronically used. But ACE inhibitors based on the HOPE trial reduce event rates. So don't forget that. And ACE inhibitors in patients with microalbuminuria or ACE or ARB will reduce the progression of CKD. So again, has multiple pleiotropic benefits as well. You could argue Plavix 75 milligrams a day is better than aspirin based on the Capri trial, all right? But dual antiplatelets has higher bleeding risk without a benefit improvement, without an outcome benefit. So again, safety and efficacy are very important, all right? So always think about that when you're talking to patients, right? What would you want to do for your family member, all right? And smoking, very easy to guide and counsel, be a guidance counselor for them, and see what are your triggers? What are you doing that's causing it? Are people in your family doing it? And just, keep on educating about the risk of smoking and what you can do to help them stop smoking. And every visit, make sure you address that, all right? Maybe they won't do this time, but next time they will. And again, you have a 50-fold impact factor by telling them to stop smoking. And I would urge you to at least look at the EAGLE trial and, render a decision, is varenicline an option for your patients? If they've decided to quit date, 40% on non-psychiatric patients and 30% in psychiatric cohort, it seems quite safe and very efficacious. All right, so certainly think about that. If not, nicotine replacement therapy and bupropion are reasonable options, better than placebo. And then finally, also make sure that you address the concerns that we have with vaping and e-cigarettes based on some of the case reports that we're seeing and a lot of the concerns that are coming from the inhalation of these agents. And diabetes is an epidemic in the US, and it is contributing to the reduction of life expectancy, and our youth are getting impacted. They're getting diabetes at a very early age with significant problems associated with that, and we need to do better in educating them about diet and exercise. And I think we need to lead by example as physicians on how to eat, and it's not easy. I struggle with it on a daily basis, but we all can do better. So we need to teach our patients to do that as well. And a dietary log, a weight log, anything that you guide is part and parcel, very important. The Mediterranean diet is an option, South Beach diet, all these different strategies are things that's something that they can do on a daily basis, and you should follow them, look at their diet logs, look at their weight logs, look at their body fat percentage, look at the waist circumference to help them, okay? And really think about not only the metformin, and the other in the insulin regimens, but also GLP-1 and SGLT2 inhibitors, because they reduce event rates. Now, again, we saw the Canvas trial had a slightly higher minor amputation rate, so do take that into consideration when you're dealing with patients with critical limb ischemia and a wound. And you should at least educate the patient about it, but it's still a risk-benefit algorithm. And then we talked about the potential growing role of DOAX, which is basically an anticoagulant, rivaroxaban, and a reduction in event rates, but again, there is an increase in bleeding rates. So These are all things that are coming up, they're here. And so you now have to navigate those waters. But the simplest thing is a statin, an ACE inhibitor, and an antiplatelet Plavix. And simply easy to stop smoking. It's very simple to potentially prescribe varenicline, and very simple to look at your diabetics and educate them on diet and exercise and weight loss. And also, it's very easy to look at their microalbumin, take a look at their feet, look for loss of sensation, educate them about good foot care, foot hygiene, and also check what their A1C is every 3 months to see that they're around the 7% range. Those are easy things that anyone can do in the clinic. All right, and then consider GLP-1 and SGLT2 inhibitors. All right, so we talked about kind of our goal of improving, keeping them alive. Let's look at improvement of leg pain and function. And it's pretty much these three things. Exercise, I showed you statin data, and salocitol. All right. So plenty of randomized trials and meta-analysis showing that exercise works, all right? The Gardner 21 study showed 100 to nearly 200% improvement in walking distance, whether it be pain-free walking distance or maximal walking distance. So a really dramatic benefit in this patient population, okay? And this is a great trial by the Natural Heart Lung Blood Institute by Tim Murphy, who's an interventionist from the Rhode Island Vascular Institute, IR doc there. And what he showcased along with Alan Hirsch and others is that if you randomize patients in supervised exercise regimen versus non-supervised, stent or no stent, in kind of in a 1-to-2 and 2-to-1 randomization, if you look at the primary endpoint, exercise won. Exercise beat even stenting in aortic disease. All right, so this is probably unexpected by a lot of interventionalists, but it showcases the power of exercise. Now, if you do questionnaires of quality of life, patients want a fast fix, so I mean, they could argue stenting there. But reality is, though, no pain, no gain in some ways, and exercise works. It takes time, it takes 6 months, but it works. Now, let's look at salocitol. So salocitol is a phosphodiesterase inhibitor, and basically, you got to be a little bit cautious if the EFs are diminished, but it improves walking distance by about 50% when compared to placebo, right? And it takes, again, 6 months. So be aware that patients have to be patient, no pun intended. But look at the walking distance. It improves dramatically at 6 months with 100 milligrams BID salocitol. Now, there are some side effects, GI side effects, that may be, some people have palpitations, so there are varying side effects, but if they work through that, it does work. You have to be patient, but it does work. And again, from not a life-saving, we talked about life-saving maneuvers. This is functionality. This is improving their walking distance, improving their quality of life. Exercise dominates, but you got to go through the pain, no gain. Salocitol works too, but it takes time, okay? Trentol and placebo are kind of, or pentoxyphylline, which is a realitic agent, doesn't really work, okay? But these other two do. But really, you should guide them in exercising. So what do? Just like a diet log, there's an exercise. We talked about 10,000 steps. When they're claudicating, I walk around the office and see when they get pain. And if they develop about a 7 out of 10 pain, if you're doing bias or muscle or resistance training, you're going to feel the burn, kind of similar to that. But at 7, you got to push it to about 7 out of 10 pain, stop until it's 3 out of 10 pain, and then go back at it for 30 minutes. And then I have them document, because you want to get feedback of how you're doing. Because otherwise, as a human, we just need positive reinforcement. And if you're not showcasing improvement, some objective measure over the months or weeks, you're going to stop. So it's a psychological point, and you need to be able to showcase, hey, there's benefit. And you need to initially follow them and be a coach of sorts to guide them through this process. But it does work. Even unsupervised exercise regimens, as has been shown by McDermott and others, works. So you can use that. You can use Fitbits. You can use this. It's worked in my practice, and certainly it can work in yours. All right. So what are my risks? What is my prescription? So certainly we want to keep them alive, right? Risk factor modification. That means antiplatelets, either 81 of aspirin or potentially 75 of Plavix, and that's what I tend to do based on the Capri trial. All right. Dual antiplatelets outside of an intervention, not necessarily the right thing in a PAD subset right now, based on the Charisma trial, right? DOACs, meaning the direct oral anticoagulants like low-dose rivaroxaban, they have some potential role in PAD. They do reduce event rates. Now, again, there is an increase in bleeding risk compared to aspirin, so you have to think about that. But perhaps there's a role, and the NICE is advocated for the utilizations in PAD. atorvastatin 40 or 80 or rosuvastatin 10 or 20, maybe ezetimibe, they're still high, or PCSK9 inhibitors if they're intolerant of statins or they're not getting an adequate response to a statin. Remember, in the FOURIER trial, there was a 70% of the patients were on high-intensity statin therapy, and their LDL drop was from 90 to 30, and their event rate reduction was significant without a real increase in adverse events. So be aware of that. All right, blood pressure control, I think you should be fairly rigorous on that, less than 130/80. And I think in the PAD population, ACE inhibitor makes a lot of sense, okay? So certainly consider that. If you look at the HOPE trial, independent BP reduction, there was an event rate reduction up to 22% in that PAD population, PAD subset. You gotta tell patients to stop smoking. The benefits are far beyond the cardiovascular, cerebrovascular, and peripheral vascular system for reduction of emphysema, reduction in lung cancer and kidney cancer, bladder cancer, head and neck cancer, so many preventable illnesses if we can get them to stop smoking. So I think that's important as a society, nationally and internationally, that we have to do better. And we certainly don't want kids to start smoking, right? And so e-cigarettes and vaping, also very controversial, especially based on some of the case reports that we're seeing of significant lung inhalational injuries. So really counsel your patients on this as well, especially younger kids. We have to prevent this repeat trend from occurring. Finally, just to smoking cessation. Think about not only guiding counseling, telling them to stop, trying to suggest an end date, but whatever works. If it's acupuncture, hypnotism, whoever, I've had patients try all these things, and whatever works, works. But varenicline, based on randomized trial data in the EAGLE trial, even in the psychiatric cohort, was fairly safe and very, very effective. So compared to placebo and even to nicotine replacement therapy and bupropion. So certainly consider that. And I appreciate John Doe from Educate, one of my former students and current resident at UCSD, part of Dr. Liu's juniors, one of the integrated residents, is the one who kind of educated me about that trial. Now, I do think that we want to reduce the microvascular complications of diabetes, and that's nephropathy, neuropathy, retinopathy with metformin, oral hypoglycemics, and insulin. But also these SGLT2 inhibitors and GLP-1 agonists have some role in reducing cardiovascular and cerebrovascular events. So remember, the cannabis trial showed a slightly higher minor amputation rate in that population, but use all that information to guide your patients as you move forward. But all these drugs have some benefit. And really, in our diabetics, we should be looking at their A1Cs every 3 to 6 months. We should be looking at their feet and educating about that, making that they do proper foot care, proper nail clipping, do they have loss of protective sensation or not? These are all important. Make sure they don't have rocks in their socks or shoes, keep their feet moist, watch for calluses that underlying will have subcutaneous hemorrhage and problems and ulcerations. Very important that you educate them and their family, and even in the use of mirrors to look at the heel, because they can't look at their whole foot sometimes. So it's very important that we do a better job in educating them. Look at their microalbumin. Are they leaking some element or protein in the urine? Can we reduce CKD in this population by making sure that an ACE inhibitor ARB and getting their A1C under control? Again, these are all things that we as clinician physicians that are dealing with this common disease population need to help assess and manage. And again, I want to not only keep them alive, but I want to have them enjoy their life, right? When we're doing cancer patients, not only do we want to keep them alive, but there's no point if they're nauseous and vomiting every day for a few extra days. So in the same way, we want to improve the quality of this, we want to improve the quality of our patient population, and their pain and leg function are important. Exercise works. There's this whole concept of no pain, no gain, but it really does work, and there's good level 1 evidence to support it. And if you look at the CLEVER trial, it was better than even a stenting, all right? So I write a prescription for them on a prescription pad. Even though we have e-pads, I write it on a prescription pad, and follow up with them on a monthly basis with a log and see how they're doing. So it's, again, you're kind of being a patient coach. And then I follow up, whether it be salocil, and bring them back to office and see how they're doing and educate them. It's going to take 3 to 6 months. It takes time. It's not going to happen overnight. So again, that's important. So being kind of a life coach or physical health coach is very important. Beyond all the pharmacologic adjuncts, we have great stuff, but really it comes back to the basics, and it starts at the youth. We need to do a better job educating our youth about dietary modifications and exercise. And we we also need to lead by example by eating healthier. you know, and I think the Mediterranean diet, the South Beach diet, whatever, orange diet is really rigorous, but whatever works for you, you should have a goal. You should have a body fat percentage, a circumference. So these are things that we should use on a weekly basis on our patients. We should look at we should use their apps. There's a Lose It app that you can use that's free that patients can use to track their weight. There's many of the phones have like an app that shows the number of steps or stairs they did. And so look at their trends. I mean, these will all help them to see how they're doing, and then log their food, log what they're eating. All right, and I think that's also very important. So in summary, this is a very, very common problem, right? 10 to 20 million patients in the US, up to 29% of patients based on the partner trial are gonna have peripheral arterial disease. So this is a problem that everyone's gonna face, whether it's gonna be your patients, your family members, your loved ones, et cetera, your friends, they're gonna have this. And so we as physicians or students that are going, gonna be seeing patients soon, we have an obligation to educate patients about this, educate the society about this, and reduce events. And brachial perhaps have a role, and certainly history and physical exams. So identify claudicants, certainly look for critical limb ischemia, check the feet of your patients, okay, educate them. Treat the risk factors to keep your patients alive. It doesn't matter. I've seen a lot of people do these amazing revascularization procedures, and yet they're not leaving the hospital without a statin. Well, that does the patient a disservice because they die a month later of a heart attack, okay? Or if they have a high risk for lung cancer, they're high risk of smoking history, and you can get them a low dose chest CT to catch a stage 1A cancer based on a national lung cancer screening trials, a 20% reduction in mortality. These are things that we should be doing. You know, because you have the knowledge of the disease, it's imperative that you also do those components, because again, we want to keep them alive. Conservative management is first and foremost. Before you go to these highfalutin procedures, yeah, we can do all this, but is that the right thing to do from a safety and a cost standpoint for society? Exercise regimens, write it for them on a prescription pad, be part of the team as a coach for them, you know, and ideally it's supervised, but if not, it still works. Look at McDermott's data. You know, there's definitely trials that showcase the benefit. Maybe a Fitbit, maybe an Apple Watch, whatever it may be, to use them to motivate them to get it done. All right, watch out for, psilocybin does work as well. It improves walking distance by 50%. It takes time. Again, exercise and this takes 6 months. There are some side effects, okay? And be careful in patients with congestive heart failure because of the kind of phosphodiesterase inhibitor properties of this drug. If still unremitting, then you can consider endovascular fix, in my opinion. And certainly our skill sets have improved. The vascular specialists of various communities, whether cardiology, vascular surgery, or IR, all are able to improve the circulation in patients in a very adept fashion. But really, I want to focus mostly on the conservative measures and the prevention and the pharmacologic adjuncts, especially the old and new, that we should be putting our patients on smoking cessation. So in conclusion, there's a lot of information in these slides and a lot of information that I spelled to you, but really it comes to statin ACE inhibitor and antiplatelet. Put them on a torba 40 or 80, low dose ACE inhibitor like 5 or 10 lisinopril, and Plavix 75 a day, and you're in good stead. And keep thinking about these, getting your diabetes under control, your blood pressure under control, right? And then checking the feet. Now, the superior doctor prevents sickness. The mediocre doctor tends to impending sickness, and the inferior doctor treats actual sickness. Well, unfortunately, I'm still an inferior doctor, but I would love to be someone who's more involved in prevention. And I hope all of you that have, will be part of this journey of reducing disease and hopefully converting these last 3 years of reduction of life expectancy in the US and going back upward. Thank you.